we're trying to kind of fight this misnomer that telemedicine is only designed to be very transactional in nature, right? So telemedicine is just one term for actually delivering care over an internet connection. But ultimately what that means and how we view the world is like telemedicine is not just meant to be transactional. It's meant to be a medium through which you can actually establish a long-term relationship with the provider that gets to know you, that gets to know your family.
Welcome to Boombostic Health, where we challenge the business of healthcare and explore bold ideas that drive meaningful change. Each week, we bring you candid conversations with top experts, innovators, and leaders, exploring the latest trends and technologies shaping the future of healthcare. Join us and be part of the conversation in transforming healthcare. Hello, and welcome to another episode of Boombostic Health. I'm your host, Bradley Bostic. This is episode 44, and I've got Craig Hittle in the studio with me here today in Indianapolis, who is the Chief Commercial Officer of a very cool company called HealthTap, and has a very interesting perspective on how primary care is advancing to become much more accessible. Thanks so much for being here, Craig.
Sure, Bradley. Thanks for having me. My pleasure.
And as it turns out, we're very fortunate. Craig is headquartered here in Indianapolis.
Yes, I am based in Indianapolis. The company is out in the Bay Area in Palo Alto, but I'm born and raised here.
So the state hasn't tried to get you to claim the headquarters just because you're here?
No, although they might want to think about that. The cost of living is a little bit better if we
They
had,
should. They should. I was saying you're probably smaller office, you said, because you guys are very low overhead, so you can bring the most value to patient care.
That's right.
But probably that small office in Palo Alto, you could have a 1,000-square-foot building like us.
Easily, no doubt about it.
Well, as I said, we'd love to have you here anytime to be around and use the space. It's part of why we have it.
Yes.
So with all that said, I've also made the connection that Craig was part of the rivalry that I enjoyed when I was at Indiana, and I was on the football team there. And there was this guy named Mike Allstott that played for Purdue, which I'm sure you were cheering Mike on, as he just absolutely destroyed our football team.
He was impressive. He's a physical runner, no doubt about it. I didn't envy the defenders who had to try to take him down.
No, it was called a concussion instantly. And that was back before they made you sit out, though. So you go in. You might not know where you are.
That's right. No, I went through that as well. Played football in high school and definitely had my share of concussions probably.
So, but anyway, we've both retained enough of that mental capacity to be transforming healthcare and love to feature innovators that are doing interesting things in healthcare. And in this particular case, we're focused in on what's happening with primary care. And there's this specific area of interest that came up when we were talking, which is this Durbin report. And it's interesting how that links back to primary care. Could you just frame that a bit for our audience?
Sure. Well, yeah, Bradley, I want to just hit real quickly on the primary care and kind of the state of play in primary care. It depends on the estimates you look at, but there's 100 million Americans that don't have a primary care doctor today, right? And there's significant barriers to care. There's significant access issues. There's just not as many physicians going through medical school and choosing to enter primary care for a whole host of reasons. But what that's done more globally, right, is it's placed a much bigger emphasis on specialty care, which costs more money, right? And so that's contributed to the wild kind of out of control inflation in this country, right? So,
So just said it in a basic way. If you don't have a primary care physician for some simple malady or something where you're concerned about, you might just show up at the emergency room, for example.
Correct.
And that's way more expensive than having a physician and who is a primary care doc that's kind of reviewing you, what's going on with you.
And it's really, to go back to our football analogy, it quarterbacks your care, right? I mean, the primary care doctors are the ones that really get to know you and get to know you longitudinally with everything that's going on with you. Specialists are obviously just that. They're very focused on a very specialized part of your medical history and your medical care. So yeah, by not having access to a primary care doctor, a lot of people will either show up in the emergency room or use urgent care. And it's not a coincidence that you see urgent care is popping up on every street corner in every major market. A lot of the health systems use that as a catchment tool to get people into the broader system, but it's expensive, right? You go and pay a copay at an urgent care level and you end up getting a bill from the diagnostics and the radiology they do. And patients are getting hit with these bills and thinking, man, if I only had someone else I could call, right, that could head off me having to take myself or one of my loved ones to the emergency room or the urgent care, could have saved a lot of money that way.
And so in the early days of this movement, when telemedicine hadn't been accelerated by the COVID pandemic and people were still thinking of primary care as something they would go to the doctor and see the doctor, Teledoc was introduced. I remember that being part of our company's health plan. And it seems like that was one of the early embodiments of this concept. Is that true?
Yeah, that's very true. That's accurate, right? So the Teledocs, the AMLs of the world, they've become telemedicine as a term has become ubiquitous, right? People, it's not a novel idea. It's not in and of itself necessarily a novel technology. And so, yeah, even to your point, predating the pandemic, there were employers that were offering you the ability to actually talk to a doctor over the internet, right? Whether on your tablet or your phone or whatever. The upkeep or the uptake of that wasn't significant until COVID hit and people were forced to actually see their doctors via, the internet, right? And so the advent of telemedicine as a industry predated the pandemic for sure, but it really hasn't been, until the last 3 or 4 years where people behaviorally are now more ready to engage with a clinician, a primary care doctor or a specialist. There's a lot of specialty telemedicine that's out
Right.
there as well.
Well, I was founder many years ago when it was new to do telemedicine, and our company was teleradiology. And teleradiology was more of a business to business way for example, a rural or remote healthcare setting to have access to subspecialized radiologists that they couldn't afford to keep on site. So it was still like very much behind the scenes, and the patient didn't know the difference necessarily. But now it's like front and center where patients could actually go first to telemedicine to over their just camera on their phone, have a consult. Is that fair?
Exactly right. Right. Yeah. The UI, the UXs, the interfaces have gotten a lot better over the years. Right. And people, I think, are just generally more comfortable talking to people over the internet, including clinicians. Right. So think back to the pandemic when, young people, old people, grandparents, they're FaceTiming with their friends, right. Just became more normalized. Right.
Right.
And I think over the past couple of years, we've seen a significant spike in demand of people that are not only more comfortable using it, but are demanding that, right? And so you think about, where 2/3 of the population lives in this country, they're in rural markets, right? And so what I think people and consumers and patients have come to realize is that if there's no telemedicine, there may be no medicine at all, right? Meaning, what I mean by that is it's sometimes a 2-3 hour drive for people, right? To get to their house, to where they live in a rural community, to the nearest urgent care or the nearest doctor's office, right? And people moved out of the big cities, right, during the pandemic, and now people are starting to move back in. But I think it's come to that realization where telemedicine is not only becoming more accepted, it's actually, as I said, consumers are demanding it. It's easier for them to get to. It's lower cost, more longitudinal. They can interact with their providers more regularly on a regular basis versus having to wait 6 months to go in and drive, a couple hours or even 45 minutes to get in to see their provider. Back to the primary care point, the wait times are through the roof as well, right? I mean, there's just fewer and fewer providers in general. Baby boomers, people aging, people are consuming more healthcare. And so you've got that constraint on supply, and you've got the increase in demand of people who are wanting to maybe get a little more proactive with their care. That creates a stress on the systems. Telemedicine is as an industry, is experiencing significant growth. And now it's a matter of how we can fine tune it and how we can actually make it more value add for not only the patients that are choosing to engage with it, but how it becomes part of an integrated ecosystem with, in parallel with health systems, with the brick and mortar locations. It's not going to, my view is telemedicine is not going to, put the hospitals out of business, of course, but it is a different modality that I think that a lot of people are choosing.
Well, I think the idea of being an inpatient or going physically to a clinic is getting more and more specialized, or people are better understanding when that's necessary and when it's not. And it reminds me of the early days of e-commerce when some people still felt uncomfortable. Some people were starting to realize, hey, this is so much better. And the jury was out on whether or not that was going to overtake the world of commerce.
In-store shopping. Yeah.
Yeah. And I always kind of like to look at these historical patterns that you can relate to other new waves of power. And I think that's what we're seeing here with telemedicine, which is like, it feels like telemedicine is pretty widely adopted, but it's still just scratching the surface. And it feels like there's this like tsunami coming of everybody goes to telemedicine first because it's more efficient, it's more convenient, it costs less for the healthcare system. There are now a big part of this, so as you know, is how the doctors get paid. Right. And in the early days of telemedicine, it wasn't recognized by the major payers, especially by Medicare,
right,
as something that they would pay for. They're like, oh, why would we pay for that? The doctor's just sitting on their couch talking on the phone. It's like, no,
right.
You're missing the point. It's
Yeah.
about providing the same level of service, but doing it digitally. Is that fair?
That's very fair. And I think going back to your e-commerce point, I think that's one interesting dichotomy that we've recognized over the last, couple of years as well, is that this advent of telehealth as a segment, right? Even how when people think of telehealth, their mind usually goes to what you kind of just articulated. It's like, okay, now I can talk to someone over the internet. Like that's great. But by definition, usually what that means, it's a very transactional, kind of acute episode, acute relationship that the patient has with their provider, right? And so when people think of telehealth more broadly, and this is a challenge, and actually, HealthTap, we're trying to kind of fight this misnomer that telemedicine can only be and is only designed to be very transactional in nature, right? So e-commerce, as you said, it's like it doesn't do justice to like what the different layers of types of commerce that are practical and that are actually in the real world, right? You could say the same with telemedicine. Like telemedicine is just one term for actually delivering care over an internet connection, but ultimately what that means and how we view the world is like telemedicine is not just meant to be transactional. It's meant to be a medium through which you can actually establish a long-term relationship with the provider that gets to know you, that gets to know your family, that understands your medical
Well, no,
history
no matter where you go, you
wherever you
have
are.
continuity with that individual.
No, it's
right?
exactly right. And so we set out to place a primary care doctor at every American's fingertips, no matter where they live or how they pay for their care. Because you mentioned too, like the challenges around reimbursement and the side of service differentials that we know hospitals deal with on a regular basis. And coming out of COVID, the government, CMS, they passed the emergency legislation to make sure that doctors that are providing telemedicine are getting paid the same that they would if they saw someone in their office. And actually there's a bipartisan bill. What they've done is they've just kind of punted the last 4 years since the pandemic. They haven't made it a permanent law yet, but it's almost there. It's going to be permanent to where like they're realizing that not only the benefits to patient care and access, but the cost and their ability to actually fund telemedicine is actually going to save the overall system a lot of money.
And
Right.
this is federal.
So, yeah, federal legislation that's got bipartisan support. There's different House bills that are on the bill on the docket currently, right? That they're going to be voting on here pretty soon. That hopefully will make it a permanent law. They may continue to punt it down the road, but it's something that I think the legislators have understood, and they've seen enough data now to realize that hey, this is something that not only are people demanding, but it's going to help us kind of curb the cost runaway train that we're seeing in healthcare.
That makes sense.
Yeah.
Okay. So circling back to where I started, which
Yeah.
I think I jumped ahead a couple steps, but I was so fascinated by this conversation about the Durbin report. Maybe share what that is, why it's relevant, and then we can link that up to what's going on with this sort of telemedicine-based primary.
Sure. Yeah. So the Durbin report from Senator Durbin out of Illinois really just raised some questions, right? As the telemedicine market, the telemedicine kind of movement in general has moved into more of the direct-to-consumer space, right? So we've all seen those advertisements on TV from the various pharma manufacturers or different equipment companies, suppliers saying, ask your doctor about this, right? And so I think there's a lot of value in that. But what Senator Durbin and a couple of his colleagues were trying to investigate to make sure of is that there's not conflicts of interest in terms of like steering people, patients, consumers that are watching or consuming different marketing or TV commercials, that there's not inappropriate steerage of patients and patients' consumption habits towards a specific drug or a specific pharmaceutical manufacturing company, right?
They're really aimed at the pharma companies, the pharma industry, and what type of activities are being utilized to get people prescribed their drugs.
Exactly.
And the impetus behind it, I think, was Durbin and his staff's view and his constituents' view that there was overprescribing of certain drugs that really weren't necessary. Is that fair?
Yeah, I mean, overprescribing in general. I think the report found and so what Durbin and his staff looked at are like the prescribing patterns for pharma companies or other manufacturers that are partnering with certain telehealth companies to basically say, hey, look, we want to, if you as a patient want access to our drugs, we can give you access to a telemedicine company, a doctor that can write you the script. And so, yeah, I think there were some generally well-founded, well-intentioned, like investigative, like things that they were looking at to say, hey, look, we just want to make sure that patients aren't being steered, incorrectly or being overprescribed. 74% was the finding that they found is that when a pharma company sends a patient to a telemedicine partner, 3 out of 4 people are going to actually get a script coming out of that, right? And so that's a significantly high number, right? That they're saying, okay, that may have been clinically appropriate, but we just want to make sure that the medical groups that are partnering with the industry, the pharmaceutical manufacturers are truly independent and are not getting paid by the pharmaceutical companies to actually send referrals. There's a whole, obviously, legislative, army around anti-kickback and the Stark statutes, all those things, which are in place for good reason. And so the Durbin report really was just the first step in investigating, asking questions about the nature of these relationships between drug manufacturers and telehealth companies to make sure that they're set up appropriately with the proper safeguards in place.
And so how does that relate to TAP?
Yeah, so we've received a lot of inbound inquiries, and we have several partners that we work with today that are pharmaceutical manufacturers, that are DME suppliers, who are really looking to establish relationships with patients at an educational level to make sure that if patients have questions about the disease that they're dealing with, and a lot of patients are dealing with a ton of different diseases right now. 40% of adult Americans are dealing with multiple chronic conditions right now. So chronic condition management has become a huge thing that HealthTap is highly, highly focused on. And also why primary care is such a critical part of the equation here is because primary care doctors have the ability to look at you holistically and say, okay, you've got diabetes, you've got cardiovascular issues, you've got all these other issues that you're dealing with. We can treat those in totality as opposed to just only treating one thing at a time, like very episodically. And what HealthTap has done and what we're doing with some of these pharma partners and these durable medical equipment companies, testing companies, is offer them a platform that patients can go to really get educated by a provider, by a licensed board certified provider that can look at them holistically and say, okay, you may have these conditions or you may have been on these medications before, but how are you feeling? How are they helping you get better? Are these drugs that you're taking, are they actually helping you be in better health? Right. And so what we're doing is trying to combat the narrative, if you will, around the Durbin report that these telemedicine partnerships with pharma are only in place to steer patients toward a specific branded drug or a specific manufacturer's drug, because that couldn't be further from the truth, right? Like that's not only that's that not good medicine, it's also illegal.
I got it.
Right.
So we're talking about healthcare done right, which is if you're a pharma company and you have a medication that's relevant to these polychronic, the fancy term for people with lots of chronic diseases, and you are able to give access to that patient and an appropriate prescription for that drug, you're doing a service to the patient and the healthcare system.
Exactly.
But if your sole purpose is to be like a pill mill where you're just pumping out drugs, and we've seen this in healthcare in general with like pain management, for example, where you end up with these pain docs who are over prescribing people for really untoward reasons. And there are lots of shades to that, it sounds like, where maybe in certain cases, telemedicine was misused or maybe vilified inappropriately because it wasn't understood what was happening. But the bottom line is with HealthTap and the partnerships that you're building with pharma, it's really about getting the right patients identified in the population. So would that mean that most of the pharma relationships that you would have would be for these kinds of chronic condition management drugs?
Yes. Yeah. Very, very, very focused on the polychronic patients that have a lot going on and are on multiple complex medication regimens. And a lot of times patients just don't have the advocate. And going back to the point we made earlier around lack of access to primary care, healthcare is very fragmented, right? Globally, it's just very fragmented. And so having a primary care doctor that can help understand the medications you're on, whether they're the right drugs for you to begin with, or there may be a cheaper, generic alternative, right? So like we have very strict like protocols in place with our medical group to make sure, and we do peer review on a regular basis to make sure that our doctors are not overly prescribing a certain class of drug like antibiotics.
So you have some sort of analytics overlay that's allowing you to do these reviews. And is there a medical director that looks at that? Or
there is. Yeah. One of our co-founders, Dr. Jeff Rutledge, who started the company 15 years ago, is our chief medical officer. So he sits over all of our affiliated PCs, and he's a data geek, right? So he's constantly looking at the clinical data and the prescribing patterns and just the general practice patterns of the doctors that work for HealthTap to make sure that we are not only looking at patients holistically, but we're not going too far off the standard deviation, if you will, of kind of what is statistically kind of normal and what you would expect to see in normal kind of physician practice behavior, right? And so yeah, and I think that's critically important. And I think the other thing that is always is not always, but frequently missing from these types of partnerships that I don't think the Durbin report really like looks at is just the educational aspect of this, right? Understanding that patients have a lot of questions, right? And obviously with the advent of AI, people used to just go to Google and get their medical information. Now they're layering that with the AI tools that are also allowing patients to bring more informed points of view to their doctors to say, okay. And sometimes they may be misinformed, right? It's debatable, right?
Well, here's what we know for sure is ChatGPT isn't always right, but
Definitely
always
not.
sounds sure.
It sounds very
It
sure.
comes
But Bradley, all the more reason why the doctor is such a critical part of that equation, right? Because people are coming
complete.
and they're wanting to self-diagnose. And you know, the Durbin report, you know, one of the key other areas they looked at is some of these telemedicine partners were actually allowing the patients to come into these portals and actually pre-select the drug that they wanted to receive a script for. That's not good medicine.
No.
That's not good medicine at all. Right?
Well, and you see these advertisements. I was joking around with somebody the other day where they were like, man, I think I need Skyrizi. You know what the ad was,
And the
like,
marketers are
and
cheering.
everybody in the commercials like at a party, and they're all like feeling
They're like
good.
happy, right?
I don't know what Skyrizi's for. I hope it's helpful. I'm sure it is for somebody. I certainly don't need it, but it sounds good.
Right.
And you think about these, it harkens back to the late night 800 number, like call this number and get some stupid thing you don't need. And that's a similar, just probably primal reaction for certain people that maybe don't have a lot of education or a lot of experience with these things. And they think, well, maybe I need that. This is a out of left field question, but is genomic information working its way at all into the world of primary care at this point?
No, it's probably a little premature in that space, in the primary care space, but I think there's a lot of genomic, obviously, research and tools and analytics that are out there that can be useful to a primary care doctor if surfaced to them. I do know that going back to kind of the innovators, like a lot of the pharmaceutical companies and the research diagnostic companies that are really looking at genomics and actually creating diagnostic programs and and classes of drugs that will be able to provide much more information sooner in a disease state development than we previously have today, right? And I think there's real value in that. Now, of course, that stuff costs money. The whole reimbursement issue is something that we're obviously very cognizant of for our patients. Hence why we don't automatically just give people brand drugs, because you can usually find the active ingredient that works just as fine in a generic. But I think on the genomic path, I think there's a lot of interesting work being done by the innovators, by industry, that will be very helpful to help primary care and enable the doctors to actually get a broader, deeper medical history, family history, all the things that they typically talk to patients about in the virtual visit or an in-person visit. But if it's backed by science as well, if you've got some data, then that's powerful.
Well, and there are areas that we're working on in our company HC1 that I should share, where we're actually able to predict based on billions of lab values who is highly predisposed to develop cognitive decline way in advance.
Yep.
Because unfortunately, once your brain has been damaged, it's very unlikely, if not impossible, that you can reverse any of that. But
Right.
if you can start preparing for that future, just like you manage diabetes proactively, so it doesn't do all this damage to your organs, you actually could have a world where way fewer people end up in these terrible situations with Alzheimer's and they're not independent at all anymore. And, you know, it's a pretty awful.
Use it to slow the decline. Right. And there's heart issues. Obviously, there's a lot of research going into you know, and obviously a lot of awareness around breast cancer and women's health in particular. Right. Another, the Bill and Melinda Gates Foundation just dropped a huge amount of money specifically for women's health research on HRT, like hormone replacement therapy, not just for the downstream benefits, but for things like osteoporosis. There's a lot of things that can, if we catch these things, you know, further in advance, we can do something about it now.
Is it just the Gates Foundation now? Is it still the Bill and Melinda?
You know,
but which is neither here nor there. But I have asked this question recently to some other people, and nobody has a definitive.
I don't have the answer either.
They're doing amazing work. Amazing. I know what they started with malaria, and that's an amazing one to address.
Yeah, but women's health is a huge one, right? That has been significantly underinvested in, right? So put
big
money
time
towards that.
Gosh,
right?
Even the example of we deliver a solution related to anemia for expectant mothers. And there's a huge amount of infant mortality that relates to a mother who's anemic. It's a completely addressable thing, but if you don't know it and you don't treat it, then it leads to complications. So, well, the world is full of possibilities. As we sit here and talk about this move to telemedicine, I know that you and I are similar age, and I remember watching the Jetsons.
Yes.
And I remember thinking, there is no way you're ever going to be able to, back then it was like we had radios and, you know, our TVs were basic, and just having a controller you could push to turn the TV on was a big deal. So this idea of like a human being able to connect with you over a video phone, that alone was this amazing novel thing.
Yes.
Now, people are growing up. They were born digital. They were born in this world where everything's available on demand. There's no way that crowd will not demand this access to primary care and this proactive relationship And I think technology helps you also, like you use this example of AI applying. And I kind of chuckled just because I've seen some recent examples where it was just like, well, that's not even close to right.
Yeah.
But there are lots of examples where it is right. But if you think about also in your business model at HealthTap, the notion of really patient specific small language models that over time are smart enough to know exactly what's going on with them and exactly what their cohort looks like and how much promise there is there, where imagine the smartest, highest end of best practices always being applied to every single patient. I think that's the true promise of this combination of technology with humans, with the primary care side.
Yeah, for sure. I think we use AI today. I'll just give you an example of how we use it. It's probably more of like a practice enablement, practice optimization tool at this point within HealthTap, meaning we have our own proprietary AI pre-visit intake questionnaire called Dr. AI. And it's no different than the text message you get from, another service that just wants to find out information about you before you come in for your service, right? But what that does is it helps the doctor not only be more efficient during the time they have with you, but it synthesizes the data that the patient is offering and collates that into a very easy to understand note that the doctor can then confirm with the patient, right? It's not prescribing anything.
So it's doing administrative work.
Yes.
And it's better for the patient and better for the doctor.
It's much more efficient for both. And it makes the patient feel like, okay, like you've heard me, because that'll be the first thing our doctors do, say, hey, thank you for filling out your history there. I just want to confirm these couple things. Yeah. And that helps them get a head start in making more utilization of their time. Right?
So in contrast to every other scenario with going to a doctor where you fill it out online now, and then you get there and then they make you fill it out on paper again.
Right. I know. It's crazy.
And then sometimes they even make you fill out when you come back the next day again.
Right.
The street.
Well, and that contributes to the abrasion of, and I think the advancement of telemedicine, people saying, I don't want to go to the office because I got to drive and there's a bunch of other sick people in there. I'd rather stay home if I'm not feeling good. I can fill out all my information digitally before the visit even starts so I can get to the visit with the doctor, get what I need and get out of there. Right. And that's just for the transactional piece. But what telemedicine also offers, I think, that's different than going to a in-person clinic is our doctors are very skilled and very adept and astute around just understanding the environment that people are in. So think about, imagine a patient who's really sick and is in their home environment. And the doctor can see, not that they're trying to be big brother, but they can see you've got multiple kids running around. You can see that your home, it's going to sound terrible, right? But they can see the environment and they can see if you're struggling with certain things in your environment that may be part of the root cause of why you're struggling as a patient with the condition you have, right? And so it gives a more holistic view that the doctor can then ascertain what's really going on here and how can I help treat all these other things? Because usually when you go in the office, they're seeing you in their exam room and you're only answering the questions that they ask you.
But it's interesting you point that out. It really kind of in some ways brings you back to the days of house calls where that's how doctors used to do it.
That's
they
right.
Used to show up to your house and they lived in a small town and there was one doctor and that doctor would go visit all the people and check on them
and get to know the neighbors, right? I mean, take care of the neighbors.
Context, and they would know if you couldn't get transportation to the hospital, for example.
Exactly. It's almost like that concierge level style of PCP. We're trying to bring that back.
Yeah, I love that.
Or at least, bring a different light to telemedicine, again, being more longitudinal relationship based. Like those are the key things. Right?
It's the benefit of concierge medicine without the extra cost because it's so efficient. It's very clear why this is better for the patient. Why do primary care doctors want to do this? What is it that draws them? Because you've got, 120 or some number.
Yeah, we've got,
all over the country.
Correct.
Why is it that primary care doctors are saying, we'd love to be part of this?
They're burned out. Right. At the end of the day, they're burned out. Right. I mean, if you go to a typical primary care office, they're seeing between 60 and 70 patients a day. And that's not, there's not enough hours in the day to do that. I mean, you're literally talking maybe 2 to 3 minutes with a patient. Most doctors are trained, right, to get to, they're scientists. They want to understand what's going on. They want to understand all the different factors that are involved in someone's healthcare. And they want to put a care plan together for that. It's very difficult to do that in 2 to 3 minutes. So HealthTap doctors have come to us because they've been in private practice before and they've run on that hamster wheel and they're like, I want to take care of my patients and I want to be paid and reimbursed in a way that I don't have to see 60 patients a day in order to earn my paycheck.
Okay.
Right. So with that comes economic model challenges that HealthTap, we have to figure that out, of course, because they should be paid well. I want them paid well. We do pay them very well. But we also want to make sure they're productive and are seeing enough patients to make sure that we're.
So is there a level of value-based orientation in those models?
Not yet. Not yet. We're emerging to that. That's where I spent some time, so about 5 years in the pop health world. And helped health systems kind of navigate into more, getting out of fee for service, moving into VBC deals. At HealthTap, we're working on that with some of our payer partners. We're getting asked more like, hey, would you guys be willing to do a capitated deal? Like where we attribute, 1,000 patients to you and you're responsible for the overall total cost of primary care. We would love to do that. We're not quite ready for that yet. There's some infrastructure challenges involved in that, right? Because we don't have any, brick and mortar locations. There's certain limitations. There's a scope of practice for sure that within telemedicine, you can't do everything that you can do in person.
I have some ideas for you. And I'll spare the audience right now. We should talk about that.
Lovely. No, I'd love to hear about that. But the other thing I was just going to mention real quickly on the AI front and operational efficiency and why doctors love it is now we've got the technology that once you're established as a patient within HealthTap, right? And the doctor knows you, they know you and you know them. We can start using asynchronous care in between visits, right? So asynchronous I put in two categories. One is just simple text, right? It's secure through
base.
But like, and we don't charge for that. That doesn't constitute a whole separate visit. It's just like, hey, you can text with your doctor if you have a question about the prescription he or she just wrote you. Right. But the other thing that's really cool is if once you're established, we have the ability to do asynchronous intake or different, almost like update questionnaires where patients can go in and say, hey, I've got these couple things that I've noticed recently since I saw you last. And the doctors now have the ability, if they know about a chronic condition that they're managing on your behalf, we can automate a lot of the clinical decisions that's overseen by the doctor, and AI synthesizes what patients
said. In a great position for that.
So that's something that we actually have some capabilities to do that now, and something we're looking to continue to build out.
It reminds me, one of my recent podcast guests, Lee Shapiro from 7Wire, was maybe the first investor in Livongo. And Livongo ended up selling to Teladoc. And for probably similar reasons to what you're talking about, which is they gave a level of automation, I think, and consistency and efficiency to how you manage people who had diabetes. Which is, pretty awesome advantage for a group that historically had been needing to manually do all that work or missed patients that otherwise maybe needed that care.
Sure.
So you talked about the way that diagnostics work as well, and you've got a connection to one of the major national labs. And does that allow you to have portability to the information? Like if I'm a patient that's part of HealthTap and I'm on vacation and something goes on, how does my medical record get,
Yeah, it's all embedded. So we have an open notes policy, right? So within the secure environment, the secure app or web version of HealthTap, our EMR is accessible. The notes, your visit notes, your lab records, everything's available to you right within the app, right? So let's say you're on vacation or you're a snowbird, you're down in Florida and you have another primary care doctor that you see down there, a specialist you see down there, and you want to show that doctor in Florida your latest lab results, right? Or notes from an office visit you had with the HealthTap doctor 3 months ago. Easy download PDF, email it right to the doctor that you're seeing in Florida, and they can have all the information right there for you, right? And so that's what our AI tool does as well, is it makes those notes from the patient visits very digestible, very concise. So not only the patient can understand it, but they can send it off to any provider that they want to send it off to. So open notes, like that's always been our policy. Like it's your data, it's your medical data, right? Under HIPAA, we all know they own the record. Careful about that, obviously, but if we want to make sure that portability is there for them.
Well, that's why you're a technology company as well, right? Where you've actually made these systems so they're tailored to provide the best value to the physician and the patient.
Yeah. And their whole team of physicians, because we don't have specialists, right? HealthTap does not have specialty care. Inevitably, patients are going to require downstream referral to a specialist, maybe at some point, right? So the ability for us to then coordinate and help the patient send those records to that specialist, so they don't have to go through a HIE or some different, a million hoops to try to get a hold of their medical records. We make it easy for the patient to share those records with the specialist that they go to. And we actually will help them make the referral too. Like we'll actually make a referral to a specialist that is covered by their health plan, or they may already have a specialist that they like to see. We'll say, hey, just if you send us your information, we'll ship the record off to them securely.
Well, and to put a fine point on the value-based care world, you definitely need to have access to primary care in order to do value-based care.
Correct.
Which is just the idea that you're paying doctors and specialists on the level of value and quality, not on the number of transactions.
Correct. Correct.
Sounds like you guys have a really good opportunity to help with that too.
Yeah, we do, and that's an emerging area, and it also helps to your question earlier about why doctors love working for us, because that enables them to spend more time with their patients. If you've got a reimbursement arrangement with a payer, or however we're getting paid with a partner under a value-based arrangement, the incentives are aligned more appropriately for you to actually spend time doing well care and not sick care, right? We all know the reimbursement system since the beginning of time has mainly been set up to pay for sick care.
Right.
Very transactional, very acute care based, right? As opposed to VBC, which should reward more holistic long-term care.
For sure.
Yeah.
Well, clearly you guys are onto something big and you bring a lot of passion and energy to this space. And I hope you're having more fun than back when you were an auditor, a consultant.
Right.
All
Definitely.
of that stuff, right?
Yes, no doubt.
But I think it's helpful to have that background because at the end of the day, the numbers have to tell the right story for these bigger picture stories to happen.
They do. They do. Right. There's still a lot of opportunity in healthcare, as you know. There's still a lot of inefficiencies, right? It's still way too costly. The 3.5 trillion, whatever we spend, we're trying to make our small dent in
I think it's 5 trillion.
Is it 5 now?
According to my podcast guest last week, literally went through and said it's 5 trillion based on this. Anyway, huge numbers, unsustainable. And that's a big reason that this podcast exists, is to bring to the surface innovations that are changing that game. So thanks for all the great work you're doing to innovate. And thanks for being on the podcast.
Likewise. Thanks for having me, Brad. Appreciate it.
All right. Well, hey, everybody. Thanks again for joining for this episode of Boombostic Health. As you know, we covered a very interesting topic around primary care, leveraging telemedicine, a super promising major component of the future of healthcare, and innovators out there who are working in this space, I think, have a very bright future. Thanks so much. We'll see you next week.